Hi, good evening. Thank you for joining us. I'm Dr. Danielle Ponzio from the Rothman Institute. I am one of the total joint replacement surgeons focusing on the hip and knee. And today the topic for discussion is same-day joint replacement. Is it right for me? By way of background, I did my undergraduate training at Princeton and went to medical school at Jefferson in Philadelphia. I stayed on there at the Rothman Institute for my orthopedic specific training as a resident. And then I went on to New York City at the Hospital for Special Surgery for what's called fellowship. And that's a year of specialized training focused on the hip and knee and specifically reconstruction of the hip and knee through joint replacement. So my focus now in practice back at the Rothman Institute is treatment of hip and knee arthritis, and that can range from non-surgical treatment to, of course, surgical treatment. And the particular procedures that I'm typically performing include total knee replacement, partial knee replacement, total hip replacement, and then revision hip and knee replacement. And revision simply means that we are redoing a joint replacement that's been done in the past for a large number of reasons. The facilities that I work out of include some of our offices, the Rothman Institute in Egg Harbor Township, Cape May Courthouse, and Manahawkin. In terms of surgery, we operate out of a hospital system that's known as Atlanticare Regional Medical Center, and that's in Pomona, New Jersey. And then what I'm highlighting here today is outpatient or same-day surgery. And we have a brand new center that's known as the Atlanticare Center for Orthopedic Surgery. That's located in Egg Harbor Township, New Jersey. And actually, I was honored to be the first surgeon to do a joint replacement out of our new center. And that was back in November of 2020. And so that was the very first joint replacement that was done same day out of our center. And now we're doing many on a weekly basis. And so I'd like to share that experience with you today through this talk and hopefully give you an idea of whether or not that may be something that you're interested in or what it takes to become a candidate for that type of surgery. Prior to kind of getting into those details, I'll just give you an overview about arthritis and then some of the treatment options that are available. So arthritis is the most common cause of disability in adults in the United States. And by 2040, we predict that there will be 78 million adults affected by arthritis of the hip and knee in the United States. So that's about 26% of the adult population. And then the chart here highlights that it's particularly prevalent in the 65 and older age group, with about 50% of people describing hip or knee arthritis that's been doctor diagnosed. Also, there's a high prevalence in females, and that's around 24% here in this chart. When it comes to treatment, this is a slide that goes over the official recommendations of the American Academy of Orthopedic Surgeons. And I always like to highlight these things because there aren't a lot of really great treatments for arthritis, and some of the top recommendations, strong recommendations, are things that patients can do on their own at home. And really the best things that you can do for your joints, particularly when they're affected by arthritis, include strengthening exercise, low impact aerobic exercise, keeping up general physical activity, and weight loss. Other treatments may include anti-inflammatories or a medication that's known as tramadol. I also highlight that there's no strong evidence for medications like glucosamine and chondroitin, and yet we see those fairly frequently in the general population. And then also knee scopes. That's a bit of a misconception, as a lot of people think that cleaning out a joint is a viable option. And that's a bit of a historical option that was utilized as a surgery to help arthritis. And we now know that that can actually accelerate arthritis. And so that's no longer a recommendation. Treatments that we commonly use include injections, and that would be steroid injections or viscosupplementation injections. And so those actually fall into an inconclusive category amongst the recommendations from our academy. So I did want to highlight that in our offices in Manahawkin and Egg Harbor Township, we have a wonderful dietitian. Her name is Sierra Beck. I work very closely with her because it's not uncommon that patients need to work on their diet in preparation for surgery and often even lose some weight. And it can be a little bit frustrating because we have a body mass index cutoff, so to speak, and that is a body mass index of 40. So that number of factors in your weight and your height. And it can be frustrating to inform your patient that when you're trying to help people, but it is there with good intent because we have great research that shows that when your mass index is at an elevated level above 40, there are complications and risks that are associated with that. And so I think it's wonderful that we offer a dietitian to help you to get yourself in a safer zone. And in addition to that, I think the experience of making that commitment and going through that time where you're kind of getting a bit healthier, lowering your body mass index, and then embarking on surgery is a really rewarding one. So I wanted to let everyone know that that resource is available if you need it, and if you're above a BMI of 40, or even if you're below. And then this is a study I wanted to highlight regarding kind of aerobic exercise and its general impact. When we talk about musculoskeletal pain and pain coming from arthritis, there are plenty of studies that demonstrate that even if you have arthritis, being physically active is going to lead to less arthritic pain. And so I see that time and time again across the span of patients that I meet and see, which is of course a very high volume, that those that are able to maintain some level of activity on a regular basis experience less pain. They require less frequent injections. They're oftentimes not seeking out surgery when I first meet them, although they may get to that point in terms of the severity of their arthritis. I think that this goes a long way. So to highlight some physical activity guidelines for adults, in general, we should certainly be avoiding inactivity and striving for something to keep yourself moving. And that can be everyday things like taking the stairs instead of the elevator at work, or walking somewhere instead of driving, riding a bike somewhere, doing work around your house, even cleaning can get your heart rate up and keep you moving. Walking the dog, choosing to park a bit further away, so things like that, or more formal exercises like going for a run, swimming, walking, biking, hiking. Weightlifting has different benefits than the cardiovascular exercises. And so 2 or 3 times per week, I would recommend incorporating some kind of weight training. And then in terms of just the activity, you want to strive for approximately 150 minutes per week of some kind of more moderate type of activity. We know that physical activity is associated with a number of health benefits, and this just summarizes all of those things here. And so, you know, I kind of always include this bit of information because I think it can't be overstated how important it is. And then part of why I went into replacing joints is to make sure that people and patients can get back to doing the things that they want to do and be able to maintain that healthy lifestyle over the long run. And so all of this sort of fits together, whether it gets to the point where you are deciding to have surgery or not. So joint replacement, it is certainly a well-established and very common procedure, and that's both the hip and the knee. And it's been well established as an effective as well as durable type of surgery that can offer pain relief. It can restore the alignment of your lower extremities and the function of your lower extremities, And most of the time, the goal there is to improve your quality of life. I'd highlight that the number of joint replacements that are happening in our country and even internationally is increasing year after year. And along with that trend, it is trending towards younger and younger individuals that are seeking joint replacements. And generally that is as a means to maintain an active lifestyle, and sometimes even to restore the ability to participate in specific types of athletic activities. So I'm going to break things down now and talk a little bit about specifics of hip arthritis, and then I'll shift over to the knee. But this just gives you a diagram to show you what arthritis might look like, a normal hip on the left of the screen, and then osteoarthritis. And so you can see the top of the thigh bone or the femur, the ball portion of the hip, and where it sits within the socket of the pelvis. And so in an arthritic hip, you are going to have lost cartilage padding that's on the ball as well as the socket side. And it's going to create a situation where there's bone contacting bone rather than a cushion in between. The picture on the far right is a picture of an actual femoral head, or the ball part of the hip, which we removed during hip replacement surgery. And that's an example of what it might look like, where you can see the eroded areas, or like a large pothole there, and irregularity in terms of the shape of the ball, rather than something that should look really smooth and cushioned and white. So in the office, when you come to have your hip evaluated, this is the type of image that we're going to be looking at. And this is an X-ray of the pelvis. So you can see both hips, and this gives us an opportunity to compare side to side and note the differences. And so the joint space is pointed out there, and that's what a normal joint space should look like. It should be symmetric. It should be coming close to about 1 centimeter of space that is going to surround the ball portion of the hip. And then in contrast to that, you can see the other hip where there's a great deal of deformity. There's bone on bone contact between the two sides. And certainly you can imagine that that's going to be a more painful scenario with any type of range of motion. Range of motion is going to be limited, and it's going to cause significant pain. There are other things that go along with hip arthritis, like shortening of the leg overall, because you've lost that cushion. And this would be a perfect indication for hip replacement. And so when you talk about a total hip replacement, this is what that would look like. You can see the X-ray and how we're recreating the normal anatomy. So we're taking away all of those bone spurs and irregular shapes that you saw on the prior image, and restoring something that mirrors the normal hip, of course, with artificial parts. And so I'll show you kind of what those parts are made out of. Here's that, and basically you have something called a stem that sits within the thigh bone. That's the anchor. The new ball that sits on top of the stem is made out of a ceramic, and then that sits within the hemisphere on the other side. Inside of there's going to be a metal, what we call shell or a cup. And then inside of that shell, there's a polyethylene or plastic liner. And so in this middle picture, you can see those interfaces. That liner becomes the new or artificial cartilage for your hip joint. And this is going to create a new surface, take away the bone on bone, give you back freedom of range of motion, and take away pain. And it works really quite remarkably well. So in terms of recovery from hip replacement, most typically we're talking about either a same-day procedure or one night stay in the hospital, going home the next day. Blood thinners are common after this surgery, and over time that has changed. It used to be that we used really strong blood thinners like Coumadin or warfarin for every patient. And now we use baby aspirin. That's typically going to be twice a day for somewhere in the range of 4 to 6 weeks. And that's to protect you while you're recovering from developing a blood clot, which is one of the risks of surgery. Hip replacement allows you to immediately place weight on your leg. And so even that day, even an hour after surgery, you may be getting up with a physical therapist to walk. The therapy for a hip replacement is walking. And so we actually don't recommend formal physical therapy for most patients. We really encourage walking, and that's going to be a graduated thing where you're starting out very gradual in the beginning, not overdoing it. And then as your body heals, you can do more and more. So in terms of more intensive activity, 6 weeks is the magic number because the internal healing that takes place around a hip replacement takes about 6 weeks to happen. In that period of 6 weeks, that healing is taking place. Once you get to 6 weeks, that's really the first hurdle when I will let patients get back to things that they want to do, particularly low impact activities, things like riding a bike, getting back to the gym, perhaps going on an elliptical, anything that you would consider lower impact. High impact activities, things that might involve jumping or landing hard on your legs, running, those are going to be more towards 3 months from surgery. And that's really just out of some caution to allow that implant to be really solidly fixed before you test it to that degree. Driving is a common question, and the average time for driving is around 2 to 3 weeks. And of course, that varies a bit from person to person, and depending if it's the right leg or the left. Most patients can return to a sedentary job by 6 weeks. Some are sooner than 6 weeks. Some, of course, may take a bit longer, and more demanding, physically active careers. Of course, there may be time built into getting back to what you normally do on a day-to-day basis. So shifting over to the knee, this is a diagram similar to what you saw in the hip. You can see what would be a more normal structure for the knee, where there's cartilage padding at the end of the thigh bone, as well as the top of the shin bone where they interact right at the knee joint. And that creates a space between those two bones and a cushion. Your meniscus is also in that space. And then when arthritis sets in, you start to lose those padded surfaces, and you end up with areas of bone-on-bone contact, as well as bone spurs. And I included this pictures to the right of the inside of a knee, and you can see the blue arrow there is pointing to the kneecap, but you're looking at the undersurface of a kneecap, and it looks very irregular, almost like a cauliflower with all that growth that's happening around the sides. Those are all bone spurs that have grown around the bone as a result of arthritis. And then there's also deep grooves in that bone. And if you look beyond that little area where the kneecap is, that's actually the end of the thigh bone. So it's sort of carved out its path, and there's grooves in both sides. And that's a fairly severe knee. And then the bottom picture shows the same knee after we've done a knee replacement. So you see that kneecap still inverted, that you're looking at the back side, and it has a replaced surface. And then the end of the thigh bone and the very top of the shin bone with the metal surfaces. In between, you can see a plastic insert. And so that would be, again, a total knee replacement. When you come to the office, again, X-ray is our primary way of evaluating arthritis. And so an X-ray like the one on the left is going to show you what a normal knee with preserved joint space would look like. And so you can see that that joint space stays pretty even all the way across and has space. When you talk about arthritis, you're going to have lost that space. And so the X-ray in the middle shows where that space has been whittled away down to bone on bone. And you can see the end of the thigh bone is contacting the top of the shin bone where those red arrows are. And then more of a global perspective on the far right is somebody who has severe arthritis in both knees to the point where a lot of deformity has been established. And so you can see that those knees are knock-kneed, or what we call valgus deformities, where the knees are coming in and the shin bones are angled outwards. And that's all related to the extent of arthritis in that individual. And then a knee replacement would serve to remove those arthritic surfaces and realign that leg to make it actually straight. So in terms of the actual components of what a total knee replacement means and what it looks like on an X-ray, this is a nice picture to show you that. So with the parts here being on the far right and then the x-ray on the left. And so you have a piece that is capping off the end of the thigh bone, a piece that's capping off the top of the shin bone. And then again, polyethylene is the material of the insert that goes in between and creates your new artificial cushion. So those are those pieces, and you can see that it's not that we're cutting away the entirety of the knee, but we're really cutting the surfaces and putting on brand new surfaces. This would be a diagram of that. So you can again see the front view and the side view of those structures and each of those parts and what that may look like. And then the picture on the far right is a picture of me and one of my team members in the operating room. And this is just an interesting thing because it's using robotics doing a knee replacement in this case. And so a lot of people have a lot of questions about robotics, and I have a lot of opinions and feelings on the matter. I've certainly done a lot of robotics, but at this point in time, I don't think it's for everybody. And I talk to patients about what may be best for their particular situation. But you can see all of those fancy devices there that are attached to the legs are called arrays. And a robot actually has to be able to visualize those things. And so in order for that to happen, you have to put drill pins into the thigh bone and into the shin bone. And so as of right now, I do reserve robotics for kind of special scenarios and maybe more complex situations. And I avoid it in particular individuals. But that's sort of what that might look like in the operating room. And then I think one thing that maybe gets overlooked often is partial knee replacement. And yet it's a fantastic surgery. It's a great option for some people. A lot of surgeons and even joint replacement surgeons don't perform this procedure. And so if you happen to be somebody that has arthritis and you're not sure if you're a candidate for this, you may have to ask, and you may even have to ask if your surgeon does this procedure or not. Because sometimes it may not be offered only for that reason. And it does have some distinct benefits over a total knee replacement. So you can see that it's much less in terms of the device itself. The picture on the far right shows the parts of a partial knee replacement. And really what it means is that we're putting new surfaces on just part of the knee or half of the knee, most commonly the inner half of the knee. So you can see the x-ray on the far left where there is bone-on-bone contact on the inner part of the knee, but there's still preserved joint space on the outer part. And so this person is a good candidate, and they usually get an MRI as well, just to confirm that the outer part of the knee is actually free from arthritis. Because you really don't want to do this in a scenario where you have the beginnings of arthritis in the other part of the knee. But if you truly have isolated arthritic disease in one part of the knee, then this can be a great procedure. And it does offer a quicker recovery, less surgery, and even a more natural feeling knee in the end when you compare it to total knee replacement. So I think something a bit unique to keep in mind. When you talk about knee surgery in general, the recovery is a little bit more extensive in my mind than hip replacement actually. And so if you talk to patients who have had both, generally they're going to tell you there's a bit more work and even more pain involved when you're talking about a knee replacement compared to a hip replacement. But really that initial recovery is still 6 weeks, and I'm going to call that phase 1 here. It can still be done as an outpatient, which I'm going to go into a bit further at the end of this talk. Or you can spend one night in the hospital and go home the next day. Again, you can put full weight on the leg right away. Again, you're going to be on a blood thinner to protect you against blood clots. And I usually do that for 6 weeks. And we favor at this point baby aspirin 2 times a day. But you are going to expect pain, swelling, bruising, and everybody's inflammatory reaction to surgery is going to be a little bit different. And so it is difficult, even for me as a surgeon, to look at you and tell you exactly what your recovery is going to look like, because it can be variable. There are certainly patients that make it look very easy and don't require much in the way of pain medication, don't have a lot of swelling, and get back to things like golf at week 2. And then there's also patients that really use that full recovery before they're back to feeling themselves. And so I think you just have to understand kind of the range of possibilities in that recovery time. Our goal is really a range of motion from 0 to 90 degrees by about 4 weeks from surgery. And by about 6 weeks, you should be getting close to your full range of motion. You still may have swelling in your knee till about 6 weeks, and even down lower on the leg. And then after 6 weeks, I would expect that the lower leg swelling is gone. The swelling at the knee may still be there, but should be more activity related rather than constant. Okay, it can take up to 12 weeks for the knee swelling to go away. And so that is, I think, one of the biggest challenges in terms of the recovery, because during that time you're doing physical therapy, and your goal is to balance doing the enough therapy and the right amount of activity against perhaps doing too much and really making your recovery slow down as a result. So it's something I often will warn, especially my more active patients, that there is such a thing as doing too much too soon. Again, the average for driving is around 3 weeks. And I would say sort of the same rules apply in terms of returning to work, depending upon how sedentary your job is. That's going to dictate how quickly you're going to get back to things. These pictures show just some basic exercises that you may be doing after that type of surgery, both working on extending the knee and flexing the knee. And I always kind of highlight to my patients that extension of the knee is really important. And yet it's often overlooked. A lot of people think I got to bend, and then they don't stretch the other way. And so if you're somebody who's had a recent knee replacement, definitely keep that in mind. Phase 2, so when you're moving forward from 6 weeks and closer to 12 weeks out of surgery, you really should be off pain medication at that point in time. But you still may occasionally need an anti-inflammatory or a Tylenol, but it should not be something that you're using routine pain medication. And then, as I said, you may still experience swelling for that duration of time that is largely activity related, with the rest of the leg looking more normal at that point in time. There are wide varieties on that as well, but I would say this is the most typical expectation for this period of time after surgery. And then, of course, our goal is to get you back to doing the things that you want to do. And so I always love receiving photos and stories from patients that are happy, or even the group there in the center. It's a group of patients that all seem to work out and run in the same area, and they often bump into each other. So it makes me happy to see them together and out walking and running after their joint replacements. So to shift gears a little bit, same-day surgery is a great option that we've actually been doing at AtlantiCare for a long time through the hospital setting. And so you could come into the hospital and be discharged the same day. And that's been ongoing for a number of years. But what's unique here is that the Rothman Institute partnered with AtlantiCare to build a center that's a surgical center, and it's specific for orthopedic surgery. So that's the only thing that happens in this building. And it's specific for outpatient or same day orthopedic surgery. And so it's a unique place to work and to see patients really in an accelerated way experience surgery and their initial bits of the recovery. I will try to highlight some of the differences, but to walk you through what that might look like, this is basically the building. The picture here on the right is our pre-op area. There aren't usually that many people clustered in one preoperative room. This was our first procedure that was done there at the center. But typically you're going to come in the morning, you're going to be in a room like this, you're going to meet your surgeon, you're going to meet the anesthesiologist, and you're going to have a nurse. And so The interactions are a bit more intimate than, say, the hospital, where there's a lot of activity and perhaps a lot of people buzzing around. It is certainly more quaint, more quiet, more focused on each individual patient's experience. And so that, I think, is a really nice part of just the day experience of your surgery. And then the picture here at the top left is kind of rolling down the hallway back to the operating room. And then the center photo there is my team in the operating room. So there's a number of people on my team you can see. I am the one that is doing the surgery, but I have a physician's assistant. His name is Michael Sharp, so he works closely with me. He's going to be helping hold retractors so that I'm seeing everything that I need to see as the procedure goes on. Also maneuvering the leg as is appropriate through the surgery. And then there's, of course, the anesthesia team. There is a scrub tech who is organizing and handing off instruments. There's a circulating nurse who is not actually scrubbed into the field, but is critically important. And I think, the biggest thing here is with Atlantic Care across the board, we have a team of people that work together. And we work with the same team again and again and again, because we're replicating a procedure that is in many ways very repetitive. And so for it to be kind of running in harmony and running at its most efficient and productive way, you want experience and a group that works together routinely, almost to the point where you don't have to speak to one another, and you know what is the next step and what's going to be needed for that given patient in a given moment. And then you can see we all wear hoods, kind of looking like astronauts, of course, masks, and 2 pairs of gloves each. We have vests on over top of our gowns. So there's a lot of gear behind the scenes that you don't necessarily get to see. And then, of course, a table full of really neat instruments that help us to install or put in the joint replacement in a perfect way. So then, of course, surgery begins. Typically, a routine hip replacement and a routine knee replacement are going to take about 1 hour to do. And of course, that can vary a little bit depending upon the individual patient and what kind of arthritis they have, the severity of arthritis. Some people are very stiff and contracted, and of course, that's going to take a bit more time to get that joint moving again. So there is a lot of variety that we see. And certainly we don't treat everyone exactly the same. Each surgery is going to be tailored to that patient's needs. Finally, towards the end of the procedure, that bottom left picture is actually implanting one of the devices. And so we're putting that in place. And then shortly thereafter, we're going to be doing wound closure. And so in general, I use dissolvable stitches underneath the skin. On the surface of the skin is a layer of glue. And so I favor that type of closure because you can take a shower with that. It gives you some waterproof seal to the top. You do not need to remove any staples or any sutures because that material will dissolve over time. And so I think overall that part of it is very low maintenance for patients nowadays, particularly compared to the past when you stayed 2 weeks in the hospital after surgery. You had big bulky dressings that needed to be changed on a routine basis. You could not shower. You had to remove things like staples. So that experience has changed a great deal. And then basically from there at the surgical center, you're going to shift from the operating room into the recovery room, where you're going to have your own private room with a private bathroom and a pretty comfortable setting to spend the rest of your day. And so that is typically an average of about 3 hours that you're going to spend with us after the surgery is over. And you're going to meet your physical therapist who's going to help you get up. So the first portion of that recovery is just letting the anesthesia get out of your system. And then once that has happened and some of the numbness from surgery has worn away, that's when the therapist will get you up and walking. And so you're going to walk, you're going to practice stairs. You have to eat and you have to use the restroom before we allow you to go home. So you have to check each of those boxes to make sure that you are able to get home safely. And then from that point, we bring your family in and transition you to getting home that day. There are a lot of checks and balances after that. You're going to get phone calls from the center on specific days after surgery to check in on you, and then you will have follow-up appointments with your surgeon. I generally have patients follow up with me at 2 weeks after surgery, and again at 6 weeks after surgery to make sure you're making appropriate progress. So when you talk about, well, who is this good for? It is true that it might not be good for everybody. And so here are just a little overview of some criteria. Number one, you have to be motivated to go home. If you hear everything I just said and you say something about it makes me uncomfortable, or I just feel like my surgery should be done at the hospital, then you may favor going to the hospital in that instance. There are people that have their own opinions on that subject. And so if you're motivated to be one of the people that are going home that day, I think that's kind of the first step. It is a good thing if you have some degree of help at home. I think we are a little bit hesitant to be sending you home to an empty house or a situation where you really don't have much help. We will often ask you about the layout at home and making sure that it makes sense, that you'll be able to get around safely and get the things that you need safely. And then, of course, the other big part of this is medical evaluation. So every patient I operate on, whether that's at the hospital or the surgical center, is going to have a medical evaluation. There's 2 doctors that we work closely with to make that happen. And so they're very informed of our specific criteria and making sure that we are doing the right thing for each patient. And they are going to make sure that your lab work is within normal, and that you don't need any extra steps in terms of workup before you go to surgery. And their job really is to make sure that you're safe to have that surgery, number one, and then to help you discern if you're safe to have outpatient surgery at the surgical center, or if you might be a patient that's better suited for the hospital and a one-night stay. Examples of that would be somebody who has obstructive sleep apnea that's never been treated before. We're going to want to monitor you in the hospital in that type of instance. If you have anemia, maybe the morbidly obese patient, cardiac history, specific things there are going to favor the hospital. And so, again, these are the individual nuances that may come up in discussion with you, your surgeon, and then that medical doctor doing that evaluation prior to surgery. And I would say that sometimes they are so thorough that surgeries might get canceled or scheduled at the surgical center and then moved over to the hospital, which can be frustrating in terms of your experience as a patient. But at the same time, I think the intent is to make sure that you're safe. And so that's the number one criteria for us, is to be sure that you're going to have a safe and successful experience. When you talk about generally keys to success, this has been an interesting evolution towards same-day surgery. Like I said, we started doing same-day surgery out of the hospital initially, and now to the point where we have an independently freestanding building where we're just doing that. And that has evolved over the years, and that's how we've developed patient selection criteria. We have protocols that have been really well thought out. Pain control has been a huge part of this, because it's not simply take this one medication after surgery, but there's actually medicines that we give prior to surgery in that pre-op holding area. And then during surgery, there's anesthesia, of course, and then there's actually medicine that we put right into the knee joint itself or the hip joint itself. And then certain medications that we use after surgery. And so we call that multimodal pain control, because we are going after controlling the pain pathway at different levels of the nervous system, so that we are kind of staying a step ahead and trying to use maybe less narcotics actually, but different types of agents to overall lower the pain stimulus. And so that's been a huge thing that has changed surgery across the board, not just orthopedic surgery, because it means that we're not relying on narcotics or things like IV medications, which of course keep you in the hospital. And that used to be the standard of care. In terms of anesthesia, I didn't talk about that too much, but a spinal anesthesia is the standard of care for joint replacement. So that means medicine going in your back, making you numb from the waist down for surgery, medicine through an IV to put you to sleep for the surgery so that you're not hearing the procedure. Although I have had patients elect to stay awake and to listen and sometimes talk to me during the surgery. So that's okay too. There's also something called a nerve block where the anesthesiologist is going to put some medicine right around the nerve. That's specific to knee replacement. But again, it's all designed to help minimize the experience of pain. Another thing that has changed over the years is we do not routinely use Foley catheters. So that would be like a urinary catheter. And so that helps promote getting you up and moving right away after surgery. And then therefore allowing you to get going to the bathroom early in the process. And of course, there are certain things where we do use a Foley depending upon some medical history pieces, but that it has been a change that's helped mobilize patients earlier, and early mobilization has also been shown to make a big difference in terms of your initial recovery. We have a bigger focus on hydration. So oftentimes we're going to let you have things to drink even very close to the time of surgery, and certainly right afterwards. And I think that makes a big difference in terms of nausea, vomiting, and just the overall way that you feel after surgery. And then lastly, I touched on this earlier, but teamwork and the atmosphere that you're in for your surgical experience goes a long way. And so at the surgical center in particular, I think they've done a wonderful job at building a team that works together well. And I think the patients feel that support, and they feel the positivity, and it makes people really thrive. So overall, it's a great setting to have surgery if you're an appropriate candidate. So that's something you talk to your individual surgeon about when the time comes. I'm happy to take any questions, Melanie, if you want to tell me if there's anything I should address. And then this page just gives you a little bit of an overview of how you can contact me if you'd like to. I do have an Instagram account that has some interesting photos and things I like to share, my email address, and then appointment scheduling phone number, as well as a direct number to my team, which is the number on the bottom, the 609 number. And thanks everybody for joining us tonight.
Thanks, Dr. Ponzio. We do have a few questions, and I'm going to start with the first one. And it says, what happens to all the muscles around the hip during surgery? Do these get disturbed or damaged?
Okay, so there's different types of hip replacement surgery. And so the one that I generally favor is called an anterior approach. The incision for that is going to be about 4 centimeters or so in length. And the reason why I favor that approach is because you're going between 2 muscles. And so you're not removing or cutting those muscles, but you're pulling one to one side, one to the other, and then working in that interval. So they're not cut or permanently damaged, but those muscles are going to be, of course, sore, like you've gotten a good stretch in that area right after surgery. And so that is part of the healing and recovery, to let your muscles recover. And one of the reasons why we avoid physical therapy, because exercising those muscles right away is not really in your best interest. But it does make for a quick recovery using that approach to surgery.
Thank you. Question, how soon can you golf after hip replacement?
So that's going to be that 6-week number, and a little different than knee replacement, because hip replacement has to heal to your bone. So your bone is going to heal right onto the devices that we install. That takes about 6 weeks before that bond is strong enough to start doing more activity. And so I'd say that the earliest is going to be 6 weeks. And for you to really be driving a ball and putting a lot of force into that motion is going to be closer to 3 months after hip replacement.
Okay, thank you. If anybody has any questions, feel free to put it in the Q&A. There are some more coming in. Question is, are hip replacements only good for 10 to 15 years?
So no. So if we look at the research that is out there now, it's going to tell us that about 30 years after a hip replacement, you will start to see perhaps some breakdown of the implants. And that's really testing that's been done on older iterations of our hip replacements. Now, if you had your hip replacement done already years ago, it would be an older device. Those devices are going to start breaking down around 10 years, 15 years. So it really depends on when the hip replacement went in, and that will dictate which problems we're looking for. So I still do a lot of my revisions on people that perhaps had surgery done 10, 15 years ago, and they've started to wear out some of the parts. The good news is now the materials that we use have gotten better and better. So those parts are going to last longer and longer, to the point where we don't really see a lot of evidence of them wearing out on x-rays, even far into the future, like 30 years and sometimes beyond. And that is one of the reasons why we are now offering joint replacements at younger and younger ages. Whereas we used to send people away and say, you just got to bear with the pain until you're a bit older. Now we have a little bit more flexibility in terms of that.
Thank you. Another question is, if I need the surgery, but I can still tolerate the pain, am I doing more harm than good of not having it?
That's a great question. And I think that's going to really depend on individual details of your situation. So, you're really going to want to talk to your surgeon, make sure they're going through your x-ray and also your exam to see how your range of motion is and how much wear there's been on your x-ray. So if you can imagine bone on bone, once you've worn through the cushion in the knee, you're then starting to wear through your actual bone. And so delaying surgery for say 10 years could result in a situation that's a bit more challenging or some cases even dangerous, but that would be the rare case scenario. I think that in the majority of these cases, if you still can tolerate pain, then you're likely not doing harm. And the only other thing I mentioned there was range of motion. So if you have a really stiff knee, for example, you wait a couple of years and it becomes more stiff, it's going to become increasingly harder for you to get back your range of motion even after surgery. And so those are things to consider when you're sort of thinking about the long-term timing.
Okay, so you did touch on this. Is this a muscle sparing surgery on the knee?
Yes, so muscle sparing surgery on the knee, yes, I would say in general, but you have to be careful about that language. A lot of the language that you hear in the news and on the radio and things of that nature are going to be sort of marketing terms, but not so anatomically accurate. So we have to get into your knee somehow. We do not cut muscle, but we're still making an incision underneath the skin through what's called the capsule of your knee to get into the knee to do what we do. And so the location of where we make that cut may differ slightly for different surgeons, but there's been really no evidence to show that one's really better than the other. And so I think muscle sparing is a little bit of a misnomer.
Would I be going home with a walker or a cane?
Okay, so that again is going to depend on you a little bit and where you are starting. If you are an independent person and walking freely, not using a walker or a cane before surgery, then you may go home with one, bring one home, but you might not need it. So, the first time you get up, typically we're going to have you use some kind of support, but beyond that, you can progress as you see fit. I do tell people with hip replacement, it is a good idea to use a cane for that first 6 weeks, although most people are going to feel better after hip replacement somewhere around week 3, week 4. And then at that point, typically they'll get rid of that support.
I have 5 steps to get in the house and then 1 floor. Would I be able to do that?
Yes, definitely. And so even the day of surgery in the recovery room, that's something that you'll be able to practice before you leave, and you'll be doing it that day. So certainly when you get home, I would expect that you can do that.
Okay, another question is, if the recovery does not take place within 3 months or so, then is it possible that there are other issues in other parts, I guess, of their body that could be contributing to delayed recovery?
Yes, so there's a lot of possibilities there. I think that, first of all, the kind of recovery that I outlined there is the grand majority of patients, but it might not be everyone. So there's going to be variation one way or the other. And it's possible that you may recover a little bit slower or a little bit more quickly. However, it's never a bad idea to have things looked at, or sometimes to get a second opinion if needed, because there are things that can go wrong with the surgical process, the recovery, the implants. And so there's a lot of variables at play. And sometimes people do run into issues after joint replacement where you need a set of eyes to look at everything that's going on and see what might be underlying that. And the other thing that you mentioned there is other body parts. And so it's really common for the back, for example, to affect the hips and the way that you walk, or to cause even pain that radiates down the legs. And sometimes it can be hard to decipher kind of where is that pain starting, what's causing it, and what are the right next steps to take to start to get things under control.
Thank you. A question: if someone has surgery in the near future and they have surgery at the hospital instead of the surgery center, what decides where I'm going?
So depends on the type of surgery that you're having. So for example, if you're having a routine knee replacement, a routine hip replacement, then that might be something you're a candidate for the surgical center. We also are looking at your medical background to say, okay, are there anything there? Are there things there that might be not so safe in a surgical center environment? If you're having a bigger surgery, revision surgery, where you're having a joint redone, those are situations where you're going to be better suited for the hospital, actually. And then there's a couple things that are out of our control, things like insurance. Certain insurance companies are yet to be approved in the outpatient setting. And so sometimes, frustratingly, we're told we can't. So some different factors.
Another question is, does walking, stepping, and biking hurt an arthritic knee? And what can be done to avoid knee replacement as long as possible? Which is most effective for arthritic knee, cortisone or gel shots?
Okay, so I touched on the activity part. I'm a huge proponent of staying active. I think the best thing you can do is to keep your joints moving and to keep your muscles well conditioned, even if you have arthritis. So go ahead and use your bike, use your stair stepper, be as active as you can tolerate. And I think that that's going to help you in the long run, even if you have arthritis. And then what was the second part of the question? I'm sorry.
Oh, I'm sorry. I need same-day procedures. Oh, wrong one. I'm moving ahead of myself here. I apologize. It went away.
I know. I thought so too.
I'm so sorry.
I remember now. It was cortisone versus gel. So
yes.
Cortisone. I think cortisone wins in that question. So
okay.
Cortisone is going to be overall the more effective medication as an injection going into your knee, compared to gel shots. Gel shots are not completely well borne out in terms of research, but we still offer them because we have so few options to try to help people avoid surgery. And it does help some people. I think it really depends on the severity of your arthritis. Once you're bone on bone, a gel shot is not going to make a substantial difference. But certainly there are patients that want to try that, in any scenario to try to avoid surgery. And I would never tell them no, but I, of course, can't guarantee that it's going to take the pain away.
For sure.
I see a comment there about stem cells. I'm just going to say same thing in that department. There's no proven evidence that stem cells are going to regenerate cartilage at this point in time. And it's an out-of-pocket expense most typically because insurance companies don't cover it, because there's no research to support its use. And so we don't generally offer it, at the Rothman Institute at this point in time.
I think a common question is, are you able to kneel after total knee replacement?
Yeah, so you are allowed to kneel after a knee replacement, but most people, and I would say maybe 2/3 of people, don't like the way it feels to kneel on the knee after knee replacement. And I think sensitivity from the incision is part of that, as well as the harder surface of metal that's underneath that can make it uncomfortable. Having said that, there are people that work in occupations where they have to kneel. And so there are things you can do. There are programs actually that are out there that you can condition your knee to get used to kneeling again after surgery.
Interesting. For partial knee replacement, is there any formal PT following surgery?
Yeah, so generally speaking, I'm going to follow the same physical therapy regimen as a total knee replacement, and usually start out with about 6 weeks. But generally, those patients are going to go through that therapy with much greater ease compared to somebody who's had a total knee replacement. But I do think it's wise to do physical therapy after both partial and total knee replacement.
Okay, and I guess we'll jump to another fun question. Is tramadol the only medication?
Tramadol, is that what you said?
Yes, tramadol.
There are other medications. So anti-inflammatories is a whole category of medicines, which would be Aleve, Motrin. There's prescription strength anti-inflammatories, Celebrex, Mobic, Meloxicam, naproxen. So any of those medicines kind of fit that category. So that's a common one that's utilized for arthritis. Tylenol is commonly used. Other prescription strength medications, that's where I think you can come into some challenges. Tramadol is a non-narcotic, so that's why I would favor that one. And that's why it's one of the official recommendations of the Academy of Orthopedic Surgery. I think once you start to talk about narcotics, then you're really getting into sort of pain management and perhaps needing somebody to oversee those types of medicines. And of course, they're addictive. And so there's a lot of things that go into prescribing those stronger medicines.
Okay, we'll take this one here. And it says, is it true that getting injections for your hip pain can weaken the hip joint?
So when you get cortisone injections, there is some effect on the cartilage in the joint over time, and if you're doing it too frequently. And so the recommendation is no more than every 3 months, so that would be 4 injections per year in a given joint. And I think if you're following that general guideline, then you're perfectly safe going ahead. And that's particularly true if there's already some degree of arthritis that you're treating, then the benefit of that shot is outweighing the potential for a little bit more breakdown of cartilage.
This will be the last question. Are those your twins?
Those are my twins, yes. So I just was saying before I started this, I need to update my picture. They're going to be 2 years old. And so now I think they're real toddlers, but twin girls, and they are a joy. And the only thing they know about what I do is that I look at a lot of x-rays. And when they see me doing that, they say, Mommy's doing her bones. So
well, at least they know what they're saying is right.
That's right. That's right.
Well, we just want to end this evening by just saying thank you for all that attended tonight. Dr. Ponzio, the information you gave us is absolutely amazing, and hopefully helps people make the right decision for themselves and gets them back to doing the things that they love. Again, our number for appointments with Dr. Ponzio, if you would like, it's 1-800-321-9999, or you see her email, feel free to email her as well, or myself. We just want to thank you again for taking the time tonight.
Thanks, everybody. I appreciate you spending the evening with me.
Thank you, Dr. Ponzio.
Bye.